Thank you all for being here, and thank you to the organising committee for giving me the opportunity to be here to talk a little bit about my physiotherapy research, but also to give us a little bit more time so we can talk a little bit more about MS Ireland and what MS Ireland is doing for research. So I'm joined by a number of colleagues. We have Ava Battles, our CEO, and Aoife Lamb, our Services Manager, Mary McCusker, our Services Development Manager, Aoife Kerwin, our Information Officer, and we all know Alison. And as Rebecca said, Rebecca's the Chair of the committee, so I'm kind of presenting on behalf of everybody, which is always dangerous when you're presenting other people's work, but we'll do our best. So what I want to do is really take the opportunity to talk to you about how the MS Ireland structures work and what exactly we do in terms of research. I want to talk a little bit about our service and research priorities, how we use research data to get to there, and then how we're making decisions about research priorities and service priorities. I want to give three kind of examples about how research has involved our service provision. We're the only national organisation that provides information, advocacy and services for people with MS, and I'll show you the range of services. I'm going to be joined briefly by Austin Fahey, who's going to talk about his PhD work looking at part of the Move Smart exercise trial that I'm going to tell you a little bit about, and then I'll come back and do a summary. So there are a number of board committees of MS Ireland. There's two probably of relevance to this presentation. So Rebecca chairs our Research, Information, Advocacy and Communications Committee, and then Edwina Dunn, who's an occupational therapist, chairs our Services Monitoring Evaluation Committee. And then in terms of that's strategy and governance, and then day-to-day working. Mary McCusker chairs the Research Information Advocacy Committee, and then I chair the Regional Services Working Group, and obviously we have Alison directly employed to look after research. So what do we do? And I think in preparing for this, I was kind of reflecting on, I think it's probably 10, 12 years since I was chair of the research committee, and we've kind of evolved an awful lot. We used to have a lot of research funding, so we used to do grant calls, and the committee was predominantly reviewing grants and scoring and deciding who was going to get the funding. But the fundraising environment has changed. Research funding is hard to come by at this stage, so really we've had a shift in that. So we do still fund research. We funded an AIMS-RN summer student last year. We fund the Dean Medal, which is an opportunity for early career researchers to go and work at a different institution to get experience working with other organisations. Alison puts together our research e-zine, which is an opportunity for you guys to share your great research with the rest of this community, but also with people with MS. And obviously, we used to have a big role in terms of networking, but AIMS-RN is certainly meeting that need, so we're delighted to be working with AIMS-RN on that. And I suppose ultimately we're the junction between you as the researchers and the people with MS who want to take part in research. So as an example of the activity on our website, there's 12 research studies up there that are looking for participants. We have put out a call for a partner to work with us in terms of mental health research, so we're delighted to work with Rebecca and Phoenix and many others in this room on an HRB application in that regard. And I'll tell you how we got to that decision of making that as the particular call for research in a second. We supported Alison, and I've forgotten her second name, who got an early career investigator award looking at gait deficits in MS. So we do lots of things. I'm involved in an EU consortium in terms of telehealth and physiotherapy research. So there's a lot going on. The website is probably the best place to find that. So how did we get to making a call looking for a partner in terms of mental health research? Rebecca very kindly set up very well my MSI needs survey, so I don't need to talk about that. There's also the HRB database, the National Ability Support System. MS Ireland is the organisation that our regionals around the country input into that NAS database. So there's data for over 2,000 people with MS, so it's a huge resource to us. We had a young person survey, we had a healthcare professionals survey, we submitted FOI requests to the HSE about people with MS on waiting lists and services, and then our community workers on the ground. We have a very large community work service in all of the counties except Sligo and Leitrim. We have community workers that work on the ground with people with MS, and they're understanding their day-to-day needs and collecting their priorities from that. And then the members of those two committees that I mentioned earlier came together and effectively said, right, we have all this data. what can we learn from this? How can we turn this into our strategic priorities for services, research, advocacy and information? So this is where we came up with. So the top need that was identified both from my MS, my needs, but also from the community workers on the ground and from basically all of the data sources was around mental health supports. So there's a research need. We need to understand, well, what is best practice in this area. There's an advocacy need in terms of advocating for more neuropsychologists within the HSE. There's an information piece in terms of booklets and website resources and webinars. And there's a service need as well in terms of we provide mindfulness, meditation, things like that in the region. So that's an example of how this priority fits into all of those different services. And you can read through the other ones there. And I suppose what I would say to the researchers in the room is these are what we're looking at as our priorities. So we're very interested, if people are interested in working with us, to answer some of these questions or to advocate for these services or help us find the evidence or the best practice around these things. So this is a very quick overview of MS Ireland's service model, and it's really just so that you guys know what's happening and what we do. So we have the information service and information line, information days, the website, huge bank of webinars, lots and lots of stuff that AoiFE organises. We've got our caseworkers on the ground, and I'll talk a little bit about that as an example of how research is informing the casework service. We have the only dedicated MS respite centre. It's a 12-bed facility in Rathgar. I'm the exercise and physio coordinator, so we have a number of different physio programs, both online and in person, both nationally and regionally, and we also have contractors of physio-yogas and now an increasing number of fitness instructors. We run wellness programs through our regions in terms of the Facets Fatigue Management Program. I talked about the meditational mindfulness as part of that mental health addressing, and then obviously the huge advocacy service that Alison leads. We have 2 active business cases at the moment. One is for a community worker in Sligo Leitrim, and the other is a physiotherapy business case wanting to replicate the 1 post we have in Galway and have 9 posts around the country to offer an equity of service around the country. So 3 examples of how research informs services. I'm just going to talk about the first 2 briefly, and then I'll expand a little bit about the physio research that I'm involved with. In terms of community work, this is Rebecca's work that she led, a really, really nice study that has been published if you're interested in reading more. And I suppose what that aimed to do was survey community workers, people with MS, and kind of do a deep dive into that and what it meant to people, what it was, how to define it. And I think it's our core service as MS Ireland, the organisation. And for me, the graphic at the top left is a really complex thing to describe because it's so different to so many people, but it's individualised based on the needs of the person with MS. So emotional, psychological support, employment accommodations, information, financial support, social support, coordination of care, disentangling the HSE, helping people navigate the complexities of that, transportation, caregiver support, participation in employment, accessing equipment, home care, family support. So it's hard. And I suppose one of the things that Frame's report came that the key thing that the community workers do is they signpost, they provide information, but they're a listening ear. Somebody described it in Leinster House yesterday as a hug. It's the person that, it's that person that's there for you all the time whenever you need it, and that it's linking people with MS to other people in the MS community. It's obviously really complicated. I'm very lucky I get to evaluate strength and balance, and you can measure those with stopwatches, but how do you measure the impact of community work? And that's one of the recommendations from this is to work out how to do that. But ultimately it helps people with MS overcome the challenges of living with MS, fosters confidence, and it gets that sense of someone's always there. So what this has led to is a major project that AoiFE, LAM and the community workers have been working on. So we did a consultation with Quality Matters about, well, how are we going to measure the effect of this really important, impactful service? The community workers have all done solution-focused intervention training, so we kind of reshaped and standardised how it's being delivered around the country. And ultimately, we're assessing the needs of people with MS, we're measuring the outcomes of the service, and we're embedding that in a system called Salesforce that we then have the data to drive developments in this area, but also to advocate for increase in services when they're needed. think you're going to hear from Joan a little bit later, so I'm not going to talk about the work in terms of peer support, but an example of, so Mary McCusker is doing a lot of work in terms of formalising the informal volunteer support system that is out there at the minute, and so Rebecca and I worked with, this was the Ames RN summer student, Linda MacDonald, who did this work. I think there's a couple of other authors I have left off, so my apologies. But effectively, that was a survey of the people who volunteered with MS Ireland to find out what their experience was, what motivated them, what were their expectations met. Very, very briefly, I think the interesting thing was that 65% of the volunteers live with MS, and a further 35% of them were a family member or a carer or a significant other. So it's the MS community is very much involved as a volunteer. And we can broadly break those volunteers into advocacy and representation, fundraising and financial support, and then recreation and social categories. But people are motivated to volunteers to help others, to give back, as Declan said, or for social reasons, to be part of a community, or because they have a diagnosis themselves or somebody else has a diagnosis. And again, it's fitting with their values of wanting to give back, increasing their personal knowledge and skills, social functions and personal enhancement. So again, what are we going to do with this piece of research, with this surveys-based piece of research? So Mary's now working in terms of developing operational procedures, setting up, again, a central management system so that we know what we're doing, we know the volume of what we're doing, we know the outcomes of what we're doing, looking at how we support volunteers and look about information from volunteers on the website. Again, measuring impact is really challenging in this area, but it does make a huge impact. How can we recognise the contributions of volunteers, and then how can we recruit more people to be volunteers? So similar, they were talking about the challenges of people volunteering or being part of public patient involvement. We also want to increase the number of people volunteering. So you can see how research is shaping what we do at MS Ireland and how it's informing the service developments. Just to talk about the physio programme, so my background, it was as a physio first, clinical physio, and then an academic for 20 years, and I'm now privileged to be working in MS Ireland and bringing that knowledge to the ground. I was saying to somebody at lunchtime, I feel like I'm having much more impact in MS Ireland than I was at a desk in UL, so I'm loving it at the moment. But one of the programmes I wanted to present is Move Smart MS. So that also came out of COVID. So before COVID hit, all of the MS Ireland programmes were in person. Typically they would be local to the person, so you might have people with different symptoms, people with different levels of ability. They were great for the social support, they were great for getting people active. But what we discovered is when you move online and you're recruiting nationally, you can get really, really stratified groups. You can get people who are newly diagnosed at 6 o'clock on a Monday evening because they all still work, and they can come into a Zoom room knowing that everybody in there is going to be the same as themselves. They're not going to be in a room with people with more disability, for example. Or similarly, we can get a group of wheelchair users online and they can work together. Oscar's going to talk a little bit more about how the role of the peer support and things works later, but effectively it's that tailored intervention because everybody's at the same mobility level. Those balance exercises are exactly what they need to do. They're difficult enough, but they're not too difficult. And the model we use is an exercise plus behavioural coaching approach. So just to talk a little bit about where that approach comes from. Before I do that, this is the kind of an overview of the programmes we deliver. So this is not me, this is Hugh. I deliver one or two programmes, and Mary is our physio in the Western region. She has a specialism in spasticity, so she delivers tone stiffness and spasms. But what you can see is it's tailored by ability. So if you look at something like core incontinence, at the moment Hugh is working with people who use relators, but in September he'll probably be working with people who don't use any device. So again, we're getting that true peer support and that true focused interventions. So where did this come from? So I had been working in UL and I had been doing a lot of work on exercise behaviour change. So Blauheen Casey did her PhD looking at the biopsychosocial correlates of exercise. So basically, what are the things that people who are physically active, what's their characteristics, or what's the things that they do that makes them different from people who are inactive? And we were also working in parallel with Rob Mottle in the States. He had a kind of an educational intervention. We had the exercise component from getting the balance right, and we were kind of merging these two together. So effectively, this was a HRB-funded study. We randomised 94 people, so everybody did exercise, but what was different was that one group had this sham education, so we talked at them about vaccines and sleep, but we brought them together so that we controlled for attention. And then the other group had really structured sessions about the outcome expectancy, so what can you expect if you exercise, goal settings, both in terms of what you want to get out of it, but what you're going to do to get there, the sources of self-efficacy or sources of confidence in exercising, barriers and facilitators, and all of this fitted very nicely into a social cognitive theory model, so that was what led to the Step It Up trial. So what we found basically was the people who had this very structured behavioural coaching approach did much better at the end of the intervention, and they maintained it at 6 months. So there's something about packaging exercise with this educational component that works. Another thing that hugely influenced the Move Smart MS programme was our Better Balance programme. I release my inner OT quite frequently. So Marcia Finlayson was a career mentor of mine at one stage. So Marcia has a model that looks at behaviours and attitudes, activities, symptoms, and environment. So if you take something like falling, it's not just about balance, it's not just about strength, it's about the environment you're in, it's about that, I'd love to talk to Fiona about that stigma piece, because there's this huge piece about not wanting to be seen using a walking aid, and that's obviously going to have a huge impact on falling. So it's really just taking this multifactorial approach. It's not just strength and balance from physio, it's all of these other things. So the modules from Step It Up are now core modules for all of the Move Smart programmes, and then that 4-step, the base model, is embedded into things like our falls prevention programmes, our balance and mobility programmes, all of those other things. So, does it work? The answer is yes, it works beautifully, and it's now one of our core services. But you can see in terms of the people who take part, we've got a good representation in terms of most people having relapsing remitting MS, but a large number of people with secondary progressive MS. And then the disease step scales basically measures the ability of people. So you can see that basically the top 5 are people who use walking aids or wheelchairs, and the bottom 4 are people who don't use any aid. So we've got about 50-50. So we've got a good representation of all levels of ability. So the participants were about 14.5 years on average since diagnosis, mean age of 54 years. And then in terms of outcomes, people with MS fall at a very high rate, so 7 falls per person per year for the people who were taking part, even though 50% of the participants didn't use a walking aid. We have that, so we brought that down to 3.3 falls per person year, which is a really important outcome in terms of healthcare utilisation and cost, but also the cost to the person of the fear of falling and stopping doing things because you're afraid of falling. Statistically and clinically significant increases in strength, statistically and clinically significant increases in walk test distance. And when you consider that 20 metres makes a difference between you being able to go out around your house and go to a local shop or walk from your car to a venue, we're seeing really big changes in 6-minute walk test distance. Very briefly, the other measures. You can see for the MSIS impact, multiple sclerosis impact scale, for the physical, psychological and total score, big changes, up around 17-20% changes, all statistically significant. And we're also making an impact on fatigue, which we've talked about a lot today, and also we're making an impact in terms of people's ability to walk. So it's a really successful programme. I haven't put the depression and anxiety results in there, but we're seeing, again, similar percentage changes. So it's a very effective programme that does make work. So I'm going to hand over to Austin. He's going to talk a little bit more about those mental health outcomes.